Good afternoon, and welcome everyone to the second webinar in our COVID Conversations series, Difficult Conversations in the Time of COVID-19. My name is Keita Scholl. I'm the Office Manager for the Coalition for Compassionate Care of California. I'd just like to take a quick moment and introduce our CEO, Judy Thomas.
Thank you, Keita, and thank you to everybody who's joining us today. We've had great number of registrations for this webinar, and I know we'll have some wonderful information that you can use immediately on today's call. I just wanted to let you know that we have started this campaign, COVID Conversations, to be a central place targeted for the folks in California to have information at your fingertips on how to talk about COVID and help people stay in control of their health care even in this current crisis. So if you haven't checked out our website, check it out. We've got resources for the public, for healthcare providers. We've got scripts, we've got handouts, we've got lots of information for you to use, and we are continuing to update that information. This initiative includes a newsletter, it includes our webinar series, and lots of other pieces to it. So if you haven't signed up for our newsletter, do that so you can stay apprised and have the latest and greatest tools at your fingertips. I also wanted to just follow up quickly from our webinar last week and let you know there was one question that came up that we had a little more information on. And the question was whether a notary, such as a notary who was notarizing advance directive, whether the fingerprint was required. And we have clarified that yes, in California, notaries are required to get a fingerprint. And there are a couple of ways the National Notary Association has provided extensive detail to our notaries on how to do that, whether it's with a single-use pad or with a reusable pad, all the steps they need to take to make sure that that is completely protected so that it doesn't spread COVID. So I just wanted to mention that before we jump into today's webinar. So I'll pass it back to Keita.
Thank you, Judy. Quickly, these are the objectives that Dr. Arnold will be covering. And I do want to let everyone know the webinar is being recorded, and you will receive an email following the webinar today that'll have a link to the recording. It's now my pleasure to introduce our presenter today. Dr. Robert Arnold is a professor in the Division of General Internal Medicine, the Department of Medicine at the University of Pittsburgh, and in the University of Pittsburgh Center for Bioethics and Health Law. He completed his medical school training at the University of Missouri, Kansas City, and his residency at Rhode Island Hospital. Dr. Arnold was named the first Leo H. Crape Chair of Patient Care. He is the director of the Institute for Doctor-Patient Communication and the medical director of the UPMC Palliative and Supportive Institute. He is clinically active in palliative care. Dr. Arnold has published on end-of-life care, hospice and palliative care, doctor-patient communication, and ethics education. His current research interests are focused on educational interventions to improve communication in life-limiting illness and better understanding how ethical precepts are operationalized in clinical practice. He is the past president of the American Society of Bioethics and Humanities, as well as the American Academy of Hospice and Palliative Medicine. Welcome, Dr. Arnold. I'll turn it over to you.
Okay, I should be, hopefully you all can hear me. If people have problems with audio, if you would just send us a chat message so that we know, because as opposed to talks where you can see your audience, I can't see any of you, and luckily you can't see me either. I'm going to start, because these are such unusual times, by making two pop culture recommendations that will only bring you joy in the next week. The first is that if you haven't watched a television show called The Good Place, you should start. Start with season 1 and just work your way through it. It's only 4 seasons, and it will bring you joy, both because it has fabulous fart jokes and because it's really about what is it to be a good person. So it's one of the few shows that both adults and children can watch together. And second, as I was telling Judy, there's this podcast by a guy who's on The Office called Some Good News, or it's SGN. And on the second episode, they have the most amazing 4 minutes of just amazing joy that involves a 9-year-old girl and the cast of Hamilton. If you pull it up and you don't want to watch the whole thing, just start at about 7 minutes and 30 seconds in, and it is the most you will smile probably in your entire day. So those are my 2 pop culture references to bring you joy and will hopefully make the rest of this worthwhile. Next slide, please. This is something that if I would have shown 4 weeks ago, you would have all been like, oh, he's been watching too much science fiction. And yet it is the case that the world is so different that from now on, this is going to be like, the world is going to be like BC and AC, before COVID and after COVID, because our clinical care is going to change. The way we talk about things is going to change. The way we, for at least the next year or 2, have to deal with patients is going to change. And so I just want to have a first slide to sort of situate us in our new world so that we are in the right mindset to think about this. I also want to acknowledge that 2 things. One is that if you like these slides, they are mostly from Tony Bach, who is one of my colleagues at VitalTalk. And if you don't like them, I chose to use them, so you should blame me. Second, some of you will have questions about legal issues. I just want to say that 1, I'm not in California, and I know that most of you are from California. And 2, I'm not a lawyer. And so I'm going to bring and answer these from a largely and answer your questions from a largely clinical view, and from a clinical view that isn't very risk averse. So I understand that in this day and age, many of you are going to have conversations that you're not going to be able to formalize into advanced directives that are legally valid, which would mean that has legally met your legislator's stamp of approval. I would still tell you that they're important to have, and that clinically you should use them in guiding your decision making. And I'm saying that as a clinician and as a bioethicist, not as a lawyer. Next slide. I'm going to split this talk up into 3 pieces. One is a 10,000-foot view. Next is what good communication offers, and this again comes from a lot of the work that I've been doing on VitalTalk with James Tulsky, who's at Dana-Farber, and Tony Bach, who's at the University of Washington. And then I'm going to talk a little bit about what comes next, with a focus on how to center yourself in having these conversations. Before I get started, though, I've been told that you all can send me comments in the chat part. If you go to the chat part and you send it to organizers and panelists, that would be perfect. Are there some things that you really want to make sure that I talk about? There are about 250 of you right now, so I'm going to give you a minute. If there are things that you want to make sure that I talk about, now would be the time to type them in the chat box, so I am oriented and don't waste your time, because I get a whole bunch of you are doing this at lunchtime and you're all really busy doing your work or trying to do this at the same time you're attending to your kids or other animals that might be at home.
Dr. Arnold, I'm getting some good comments.
Oh my
People
goodness,
would like.
I'm not seeing any of them. Huh, okay.
I think they're coming in on the question box, so I'll share them with you.
Perfect.
Balance between good information and not scaring people. Please share your thoughts on how to do that. Specific language, phrasing, questions for having difficult conversations with patients and family members about possible decisions ahead, dying alone, etc. How to frame the decision to go to the hospital or to die at home when at home the families around might not be a safe option, yet the hospital death doesn't sound like, you know, where people want to go. Addressing, in particular, speaking to families of those with dementia. Let's see. Discussing the differences between advanced directives and pulse. Many patients think an advanced directive is enough. And let's see. Can you address cancer patients who are having to delay treatments?
Okay.
Yeah, some really good suggestions.
Great. That'll get me started. If you can just keep collating them, and once we get through communications, I'll ask for other questions. So as I give this to those of you in the audience, I want this to be as helpful as possible. So the more things that we have to bounce off of, the better. So send them in, and the staff and Judy will collate them and get them back to me. So let's start. Oh, next slide. I keep trying to move the slides myself and it doesn't work. Next. Okay. Again, just to put us all on the same page, this started in December. The first person who returned to the United States from Wuhan, China was in January 15th. Remember, initially they thought that there wasn't person-to-person transfer spread, neither from China nor from the CDC. Next slide. It's now expected that there'll be 60,000 deaths in the United States over a relatively short period of time between basically February and August, with very large confidence intervals. I should point out that these numbers are way less than the numbers that were predicted initially. And this website, if you haven't seen it, is a great website because it gives both data from the United States as well as data from whatever state you're in about the number of hospital beds, the number of ICU beds, when COVID is expected to peak in your state, and whether there will be anything that looks like a crisis regarding hospital beds. Next slide. I would point out that the communication issues that are raised by COVID really are no different than the communication issues that you've been dealing with for the last 5 to 10 years. It's advanced care planning with people with serious life-limiting illnesses who might die in the next year or two, and you're not sure exactly when they're going to die. It's about giving serious news to patients and families. The news that families can't be with their loved one is just another piece of serious news. It's like the serious news that you're worried their loved one is going to die. And so I've had a lot of questions from social workers in my health system who want to get us to bend the rules about family members coming in. And to a certain extent, I think that's a bad idea because it means that we'll continually have this trying to argue with and change the system, as opposed to just being comfortable with the fact that this is another piece of horrible news. It would be like if the family lived far away and didn't have a car and so couldn't get in. I think getting our head around the fact that it's just another piece of bad news for patients and families. A lot of this is things that we're already good at doing in terms of talking about goals of care in critically ill patients. These are conversations that before COVID, you all were pretty good at having. And so I think that COVID makes us feel like we're doing it in a sprint because we're having a lot of these conversations all at once. And yet I would say that the conversations are similar conversations to the ones we used to have. Bereavement is way more common, again, because we're having a larger number of bereaved family members. And yet again, for many of you who work in hospitals, who deal with patients who have trauma, this sort of unexpected deaths that are too quick, in which we don't have time to plan, are similar to the issues that you've already dealt with. Next slide. What's unique? Well, I think what's unique is fear and uncertainty. I think that the problem is that it's so hard from our point of view and from the family's point of view, because these are often conversations that we're having with the family because the patient's really sick in the hospital. They're conversations that they're worried because it's so quick. It's also, I think, for many families, worrisome because they've seen their loved one. And so they're worried about their own well-being. The uncertainty of whether they would ever get to go in and our uncertainty about prognostication, I think takes the issues that we've always dealt with and makes them more uncomfortable. I think typically, the literature suggests that you get 75% of the knowledge of communication is by seeing the person. And yet we're asking many healthcare providers to have these conversations without being able to see the family members. And even if you're able to use Zoom or FaceTime or video or any one of the other virtual communication tools, it's really hard to do. And my experience is that families often have trouble keeping the camera pointed at their face. And so it's still this other piece of technology at a very emotional time. Finally, I think there are loneliness and identity issues. Again, my experience has been that what's been as hard for families as the dying has been is that they haven't got to be there with their loved one. And there is this sense that a good husband or wife or son or daughter is supposed to be with their loved one as their loved one is dying. And so you're giving two really big pieces of bad news and one piece of bad news that in fact leads people to question whether they're doing everything they can. Or as I was in a conversation last Sunday night with a daughter, the biggest issue is she felt like she had failed her mom because she couldn't be there. And that's really hard to hear a family member sort of expressing such worry about whether she's being a good daughter. Next slide. Okay. So what does communication have to offer? And why are so many of you on this webcast? Is because in fact you're like, ooh, given those old things in a sprint fashion and with this new fear and identity issue, what can communication skills do? Next slide. Well, Tony, James, and I published something about communication skills in the age of COVID. And I think what it has to do for many of you is that it gives you the opportunity, despite the fact that this is all unfair and it sucks and it feels completely out of control, it allows you to use your really good communication skills to build connections with patients and families in a way that will allow you to feel that despite the helplessness and hopelessness that one may feel in a pandemic, you can gain some control and you can walk patients and families through this time and feel like you're a really good healthcare provider because you're able to care even if you can't cure. Next slide. And so I'm going to now give you 4 sort of tips of what you can do. First, one of the first questions is, how do I give this information so that I don't scare people? And I'm going to tell you that I'm not sure you can do that. If you're an American who looks at Facebook or watches Fox News or reads the New York Times and you're not a little bit scared, you're not really very, I worry about you. Scaredness, you can't keep people from being scared. What you can do is you can deal with their scaredness and try to guide them. Once you do that, I would argue that it's not your job to keep people from being scared. And in fact, if they're not scared, there's a bigger issue. What can you do? You can provide information to them in a way that they can understand it. Too often as healthcare providers, we provide information in ways that what the family or patient's first reaction is, so what does that mean? And whenever a family says to you, what does that mean? It means that you didn't give an understandable headline. That is a 1 or 2 sentences about what's wrong and what do you think it means for them. I will tell you that it's really hard to give understandable headlines because one of the disadvantages of being an expert clinician like all of you is that you've learned a new language and you need to translate it back to the old language of a 4th or a 5th grader. And the reason I'm saying translate it back to a 4th or a 5th grader is what the data shows us is that's the health literacy of most Americans. And so the first thing that's really important in giving these conversations is to be really clear about what do I want them to take home. And most of us can only take home 2 or 3 points. So give clear headlines. Next slide. Next, if you realize that you gave a clear headline, you should understand, particularly if it's in the time of COVID, that what you're going to get are strong emotions. And what we know about brains when they get emotional is that they don't listen to cognitive material very well. So when you hear strong emotions, after you've given clear headlines, you need to attend to those emotions. All I need you to do from a very simple point of view, on VitalTalk, we talk about 5 different things. If you just acknowledge them or name them. And acknowledge them and name them in a very straightforward way. I'll often say, I wish I didn't have to tell you this on the phone. It's really hard because I can't, it's such a weird time. I can't even, hold your hand. Or this is unfair. All of this is just so unfair that this is happening. Or, the uncertainty of what's going to happen next must be really hard to deal with. The more accurately and completely that you can attend to emotions, particularly after you've given clear headlines, the better off you will be. Next slide. The third thing I'd like you to do, particularly when you have goals of care conversations with families, is start at the goal before you get to strategy and tactics. That is, start with what's important and what do you want to avoid? And then as a clinician, you can make recommendations about the 1 or 2 strategies that you think are most likely to achieve their goal. I was on a call before this, and the analogy that someone used is, if you're a waiter and you talk to the person who's buying the meal and they say they're a vegan, you don't offer bacon for breakfast. If somebody says, oh my goodness, I just don't want to be alone at the hospital, I need to say, it sounds like what's most important is you being home with your family rather than going to the hospital, even if that'll help you live longer. And they would be like, yeah, then I shouldn't offer going to the hospital. They've told me their goal. And to the degree that I can listen closely to the goal, I then can make recommendations about strategy. Next slide. Finally, I'm going to give a hint. I'm very old, and I have for 20 years tried to talk about advanced care planning in a way that wouldn't get, oh, I don't need to think about that. Now, in the era of COVID, you may get a little less of, I don't need to think about that. And yet, I just was talking to cancer patients on Tuesday, and when I talked to a patient about cancer, they were like, oh, I don't want to think about that. And so I've come up with an analogy that I think almost always works. And the analogy goes something like this. The patient says, well, I'm not sure why I need to think about that now. And I say, when your kids were little, did you talk to them about what to do if there was a fire in the house? And 90% of people say, yeah, of course I did. And then I say, did you want there to be a fire in the house? And they're like, no. And I think that's how I think about advanced directives. We fill them out. We make sure that your family knows it's the protection for them. And then we put it aside and we hope we don't have to use it. It's just an insurance policy, like you're talking to your kids about what to do if there was a fire. I think the reason this has seemed to work is that often people think that if you're bringing it up, you think it will happen. Otherwise, why would you bring it up? And so for me, the critical question is, did you want there to be a fire in the house? Because then they're like, oh, I see, I did things preventatively, not because I wanted them to happen. So I'm now going to reach out for questions. I think that one of the things I would say about dying alone is I don't have a way to make that better. And so when families say, isn't there some way that I can come in? I answer pretty straightforwardly. I wish there was. In this very unusual time, there isn't. Now, I will acknowledge that there are workarounds from FaceTime to sending pictures, and yet I need to just, I don't promise things or sugarcoat things that just aren't possible. So our organizers, what other questions have come up?
Hey, Kata, this is Judy, and I took a look at the questions that we received at the beginning, kind of did a little bit of a summarizing them. So I think one of the questions or one of the themes we're hearing is, you know, how do you frame the conversation with the decision about going to the hospital versus staying at home? There's a sense that a lot of people still don't understand, you know, that hospitals limit the visitors. And, you know, there's a lot of factors in those kinds of decisions about whether to go to the hospital or not. So how do you frame those conversations?
I would frame it as, you know, one of the things we're trying to talk to people about is if they get COVID, you know, and I'm talking about people with serious illness or very advanced age. Some people say, oh my goodness, I don't want to go to the hospital where they might, I might need oxygen and my family can't see me. And if I get a lot worse, I'd have to make decisions about machines and stuff. And a lot of people don't live anyway. And other people would say, oh my goodness, doctor, I would do anything to go through to have a chance to live a little longer. Tell me about which kind of person you are. I sort of presented as some people would say this and other people would say this. Now, what would even be better is to say, what have you heard about COVID? Do you know of anyone who's gotten sick like that? It would be it would be better, in fact, if I said, one of the reasons I'm talking to you is we're talking to a lot of our sick people about COVID because I know that people have a lot of questions and are often really worried. What have you heard? Would it be okay if I talk to you a little bit about the things that we're concerned about, that I want your opinion on so that I do a really good job of respecting your views? What other questions?
Well, related to that is for palliative care patients that are at home, people who do decide to stay at home, do you have any advice on discussing COVID in light of managing their palliative care needs at home?
So that's a different question, right? That's a question of, if they start to get sick, what resources do I need to make sure that are in place with my home-based palliative care programs or my hospices, that they can do a good job of caring for them? And that's going to depend on the resources that you all have. I know that California has better home-based palliative care programs than a lot of us do. And I think that if you have these conversations and people say, I want to stay at home, it commits us to really being able to stand up and provide good palliative care and symptom treatment for these patients at home. Now, I get that there's some instances that are going to be really hard. For example, if they live at home by themselves. And yet I think that as healthcare providers, it isn't just having the conversation. Once we get what's important, we need to be able to provide the support and clinical skills to match our words and our promises of comfort-based care.
Great. Thank you.
Other questions?
There's an observation that in the media, there's been a lot of focus on getting vents, kind of getting out ahead of the surge. And so there is kind of this perception for people who are definitely watching the media that, like, if we just get enough vents, it's going to save us all. And that's what we need. So any advice you have on kind of countering that perception?
Well, I think that there is clearly that view. And yet I'll often say, it's the same way I talk about CPR. I'll say, and I'll say this to hospital patients, if you get a lot sicker and they need to put you on one of those machines that breathe through you, you've probably read about them in the paper, they're called ventilators. And I'm talking about an 85-year-old, so I want to paint about 80% of those people, even when they go on ventilators, it looks like a large percentage of them don't survive to go home. They die in the hospital. And so some people would say, oh my goodness, I don't want to go through that if there's only a 10% chance of me getting better. And other people would say, oh no, doc, what's most important is that I have any chance to live longer that I can have. And so I present it as honestly as I can, using some of the skills that some of you may have heard Gretchen Schwarze use in sort of best case, worst case scenario planning. And then I see what the patient says. I do think it's really important, if I'm having these conversations in the hospital, that I try to audio in their family, because I think if I have a conversation with a patient and then the patient talks to their granddaughter, if the granddaughter doesn't understand it, she will spend all of her time trying to talk her grandmother out of her decision and be mad at me for raising the issue with her not being able to be there. Let's go to the next slide. We have tried on VitalTalk to put together a whole list of communication skills in a playbook, where what we've tried to do is we've tried to put together, you know, how to counsel people, how to talk about admitting the patient when the patient comes in the hospital, how to talk about when the patient, someone might want to opt out of hospitalizations. We've tried to come up with what we think are the most common scenarios and give you exact words, as well as if you click up on the top, we give you videos that you can watch people try to have these conversations, and they're translated into a variety of different languages. Now, they're not going to deal with every conversation, and you know, there's something to sort of get you ready to begin to think about what the exact words are that you would use. Next slide. That's just the PDF. Next slide. So for proactive planning, we've given you an acronym called CALMER, checking in, asking about COVID. Here's something I want us to be prepared for, motivating them to talk to their proxy, expecting emotion, and then recording the conversation. It's exactly what we talked about when we talked about how to have that early conversation and put it in context. Next slide. We also, in an app that's both for Android and iOS, put all of this in our VitalTalk app. So it's both, you can both get it on the web, but you can also get it on an app that, by the way, is free. And so we want to encourage you to use these things. The other thing that we want to encourage you to do is tell us what works for you. Because we crowdsource this with people who have gone to our courses, and so we think it's pretty good. And yet my sense is that all of you will come up with words that work for you that aren't exactly our words. And we want to hear from you about the words that actually work for you. Okay, other questions about communication issues?
Do you have any advice for dealing with people with dementia?
I think that's a great question. I think the question for demented patients is, you know, the sort of surrogate decision making. If your dad was sitting here and could see what was happening in the world, what would he say would be most important to his care? What would your dad want to avoid? Some people say that, oh my God, my dad would hate to be in the hospital when he's confused and he doesn't know people. It's horrible for him. And so I did want to throw that out because you might not realize that if he's in the hospital, you're not able to go see him. And I wonder if that would be something that would matter for him or for you. To a certain extent, I view much of this as having trial balloons that I float up to see how the family responds to try to get their sense of how are they thinking about this? What is their sense of what their dad would say? What are their worries? What is most important at this time to make this meaningful for them or to have it give them some meaning? Other questions?
We also have a question about people who are cancer patients and have to delay their treatment because of COVID.
Yeah. So I view that. Yeah, I'm sorry, I asked the question.
Yeah, that's it. Thank you.
So I think that's just a matter of bad news, right? I wish you didn't have to delay your cancer treatment. It's really scary to sort of feel like you either have to go in to get chemo and have all the risks of being in the hospital, or you have to put it off. There is a certain sense that I can't change that reality any more than I can change the reality of whether their cancer progressed or not. And it is normal for them to respond to that news by being anxious. It is, I don't want to reassure them that it won't have an effect. I can say, what did your doctor say about whether it's likely to have an effect? I can acknowledge that it's normal to be anxious. I can then ask them how they've dealt with anxiety at other times in their life and change the focus from attending to emotions to seeing if I can help them use their strengths to cope with it. And yet, I shouldn't be surprised if their normal reaction is to be really, really scared. And I should acknowledge that scaredness and not try to make it better. Because in fact, there's nothing I can do to make that scaredness better. Any more than the people who I've spoken with who are worried because now they don't have a job and they're unsure how they're going to pay for their health care, or they don't have their rent. I mean, all the horrible things that have happened, to a certain extent, I can't cognitively reframe them as being good because they're not good. So I need to acknowledge them and see if I can help them move on to live in their life despite the increased anxiety that they're feeling. Other questions?
Yeah, we have a question about, how do you talk about CPR in this time of COVID, knowing that if someone does code, it can be very, the contagion that can happen in that process and the risk to staff. So what advice do you have about talking about CPR in time of COVID?
So first of all, staff should not be put at risk. So if someone codes, people need to have PPEs on before they go into the room and do CPR. I don't think we have enough data about the prognosis of CPR in people who are COVID positive. I think we don't know very much about, at least I don't know enough about the prognostic estimates. I would imagine they are no better than CPR in other chronic conditions or sepsis. And if I didn't think it would work, again, I don't talk about CPR as an option. I say, tell me about what's most important. Tell me about what you want to avoid. Some people are like, oh my goodness, doctor, if the doctors all think I'm dying, I don't want to be on all those machines and go through that stuff you see on television. Other people are like, doc, if you think there's any chance, I'd be willing to go through those things. I think my sense of this is that we should be patient-centered. If someone says to me, doc, if the doctors think I'm dying, then, don't do this stuff. I then say, can I make a recommendation? And given what you've told me and what your values are, if your body should get so sick that your heart stops, we shouldn't do those things that you see on television. That is, I am more than okay to make what Randy Curtis calls informed assent, as long as my informed assent is based on the patient's values. Some of your hospitals or healthcare institutions may have COVID-specific CPR policies, I think that's a separate issue that is not really a communication issue, so I'm going to punt.
Yeah, and what I'm seeing in California is that our hospitals are approaching this, that people should be having conversations about that topic rather than any sort of blanket policy.
What I would say to you is that you should have wise conversations rather than the conversations that James Tolsky showed 20 years ago and Wendy Anderson showed about 6 years ago that most clinicians have, which is if your heart stops, do you want us to try to restart it? Because that doesn't give any information about the likelihood of success. And most people, as has been pointed out on television, the likelihood of success of CPR is about 70%. And so it doesn't feel like such a bad thing if they can just restart it. The other question that it's come to me as I've been giving this talk that I ask a lot routinely is when I say to people, what do you know about COVID? I'll often say, when you Google it, what does it say on the web? Because all of us, when we don't know something, we all Google it. And so I want to, before I give my headline, understand exactly what people are learning from the web, because some people listen to Rush Limbaugh and some people listen to NPR. And so the information that they come to the conversation with may be very different. And I need to know that before I start giving information. What other questions?
You know, in your answer, you used a term that I have not heard before and maybe new to some of the listeners as well, and that is informed assent. I think many of us have heard of informed consent, which is a concept that's been around for a very long time. So could you just talk about how informed assent is different from informed consent?
Yeah, so the way that I use it is that my job is to ask about goals and then based on goals to make a recommendation where I say the things that we should do and I say the things that we shouldn't do. Now, in some cases, I can't tell based on what they've told me. And so I say, we have, given what you've told me, I would suggest these two options. Sometimes, though, I have a pretty good idea. The patient who says, Doc, I don't want to be in the hospital if I get COVID. I've seen what happens in people who are 80 years old. I want to be at home with my family. I then will say, here's what we ought to do. I don't say, well, there are two options where I have to discuss all the alternatives. I ask for their assent to my recommendation rather than to consent among choices. There is about 2 to 3 weeks ago an article by Randy Curtis about this where he lays some of it out. I would just argue, be careful. Your recommendation needs to be based on patient values. Otherwise, it runs the risk of being paternalistic. It shouldn't be what you think is the right thing to do. It should be based on what the patient or family has told you is most important to them, and you're trying to operationalize it for them. Does that help?
I think that is a really important point, so thank you for stressing that. We also have a question about your suggestions with someone who does want a ventilator, but if things happen in the future that we don't have capacity to provide the ventilator or other treatment that people are requesting, what's your advice on how to handle that?
So if someone said to me, oh my God, Doc, I'd be willing to go to the hospital and be on a ventilator, I just want to live a little longer. I'd say, oh, okay. Are you able to think about a situation where you'd be like, oh, I'm not, if I'm going to be stuck like that, it wouldn't be worth doing these things. Or, that makes a lot of sense. Some people say they're willing to try, But if the doctors think they're stuck on the machines, or some people say if they're not able to interact, if they think if I'm going to be a vegetable, then I wouldn't. That is, I try to sort of begin to then see if they're willing to think about a time that they wouldn't be willing to go through certain things. Now, some people are, and some people aren't. Some people are like, I don't want to think about that. I just want to take it one day at a time. And I'm like, I hear you. Who should I talk to who do you trust if I can't talk to you? Because I don't want to burden you with this sort of what ifs. And yet I want to make sure that we know who to go to if something should happen. I do outpatient palliative oncology, and there are some people who are unable or unwilling to think about these issues. It isn't my job to push them to where I don't think they can go. And in fact, pushing them almost never does any good except for make them hate me. My job then is to acknowledge their inability to go there, to see what happens over time, something that in COVID we may not have, and to see if there are other people who are more psychologically able to think about bad news. Next slide. Next slide. This is if you go to the videos, they're very short videos. This one's only 2 minutes and 24 seconds. And they'll give you a really clear way of how a doctor, for example, can talk to a family member about how to say goodbye who can't come in and see them. Next slide. There also are on the CAPC and on the California, on the website of CCCC, great resources that you all can look at. I would say that there are more resources about how to have these conversations in the age of COVID than you possibly could want. I would say look at a couple, come up with your own terms and own way to talk about it. Next slide. So I do want to spend just a minute talking about sustainability. Next slide. We shouldn't underestimate the psychological trauma that our doctors, nurses, social workers, chaplains, and others are going through, both because of their own anxiety about their own personal worry about getting COVID, about the degree to which this has seemed like a sprint, and yet it's going to turn into a marathon, and the degree to which we've had to have these conversations back to back to back. Next slide. I would tell you that there are a variety of websites that focus on sustainability and how to deal with your own emotional valence. There's, for those of you who do pediatric work, Abby Rosenberg has a fabulous article in JAMA Pediatrics from this week. Tony Bach has built this fabulous website called Decompress that talk about how to sustain yourself. I would point out that as you think about sustaining yourself, to the degree that you can think about the meaning that you're getting in having these conversations and the help that you're doing, I would argue that you probably do better in building resilience than spending all of your time worrying about the future. We are really good as palliative care doctors and nurses and social workers in helping our patients and families cope in times of severe anxiety and uncertainty. We need to think about those same skills of how we help others cope by building their resilience and focusing on their positive strategies. And we need to have those conversations with ourselves. If we spend all of our time worrying about what ifs, we will not help ourselves do that. So I just want to sort of summarize by really pointing out that at the same time you need to learn all these skills, you also need a way to internally build your own resilience. Because these are very hard conversations in a time that is extraordinarily stressful, in which change is just so fast. And if we're not able to be centered ourselves, we won't be able to have these conversations. So we have about 6 more minutes. What other questions have popped up or do people have?
We do have some attendees that are serving a pediatric population. So if you have any advice for them about these conversations during COVID, they'd appreciate that.
I'm not sure there's a big difference. I think that the data is pretty different. That is, the data looks much better for children than it does for adults. And yet I would say if I was a parent, I would be just as anxious, and it would be really hard for me to believe that data. And so I think that some of it is to ask, would you like to hear what the experience is? That is, I wouldn't discount their anxiety because that's their lived experience. And then I would say, would you like to hear what our experience has been? And see if they're willing to hear very small pieces of information. And whether that information in the sort of cognitive reframing helps them approach the issue any differently. What other questions?
We also have a question from some of our social workers on the call about how they can best help support the physicians and the nurses who are often the front line of this work and initiating these conversations.
So I think the way to do that is to be clear about asking about positives. First of all, just asking if people want to talk. That is, they may just need to express emotions. The second is not assuming that the emotions are all going to be bad emotions. I have to say, I've been doing calls at Mount Sinai, and the strongest emotions I'm seeing is how families love each other. And it's largely been uplifting to see how families care about one another and are just trying to be the best husband or wife or son or daughter that they can. And if someone came to me and just wanted to talk about how stressful I was, I mean, I'll talk about it because I'll always go there, but it wouldn't sustain me and it wouldn't help me be resilient. It would just make me a little more anxious. And so I would be sure that as I have these conversations, I focused on resiliency and I focused on positive attributes and how these conversations gave people meaning, as much as I focused on negative emotions. Because I think it's particularly easy for those of us who do palliative care to focus on the negatives. Other questions?
How do you frame issues when, such as going to the ICU, when people see not going to the ICU as giving up?
I would say, tell me what you mean by giving up. It sounds to me like you fought for the last 30 years and, you're saying this isn't, it's like throwing good money after bad or bad money after good, whatever that analogy is. It just feels like this is where we are, and the time that you have, it just isn't like a good thing. I know the giving up language. It's the language of America, where it's always better to try. And yet, I just need to let them talk it out. I would try to be interested in what they mean by giving up, and whether I can attune to that and stay really close to their fears and help walk them through a conversation so that they can restructure how they are making this decision. For a lot of people I've talked to who are 80 or 90, it's, when it's my time, it's my time. It's not giving up. It's acceptance of the fact that you've lived a good life and you've really enjoyed the things that you've done. And this is just causing more pain than pleasure. Seems to me that's using the wisdom of elders. So to a certain extent, I see if there are opportunities to cognitively reframe. But they need to come from them. They can't be my reframing too quickly, because then it just feels disingenuous. What other questions? So finally, I know that some of you are leaving. If you guys have questions or you try this and you're like, oh my God, he is such a loon, this so does not work, please send me an email. My email is RABOB, Robert Arnold Bob, at pitt.edu. RABOB at pitt.edu. Feel free to email me. Tell me what's worked. Tell me what hasn't worked. If I didn't answer your question, tell me what your question is, and I'll do the best I can. This is something that none of us have sort of gone through before, and so we ought to go through it together and see how we can help each other both find the meaning that is why we do the work that we do, and sustain each other so that we can do this. Because it is a marathon. It's not going to be a sprint.
Thank you, Dr. Arnold. We so much appreciate this great information that you've shared. Thank you for all your great questions. We do want to let everyone know the next in our series of COVID conversations is scheduled a week from today with Dr. Seiko Izumi, who will talk about team approaches to assisting patients with advanced care planning. We'll send a link to that registration in your follow-up email, as well as links to the webinar recording as promised. And thank you all again for being with us. We hope you have a great day.